I'm going to give it a couple more minutes to let everybody in, but thank you for joining me another Wednesday night for Conversations with Melissa. This is for sure one of my favorite people in the universe. And so I've been looking forward to doing this topic for a couple of months now. What we're going to talk about tonight is the COVID effect on melanoma treatment. And we have the pleasure of having Dr. Hussein Tawbi today. He is the Deputy Chair of the Department of Melanoma at MD Anderson and Director of the Melanoma Clinical Research and Early Drug Development Program there. He's also the co-director of their Brain Metastatic Clinic, which is super important. It's such a forward-thinking clinical trial group, and you have been doing work with that for as long as I've known you. So you have so many accolades that it could take me 5 minutes to talk about them all. One of which is, you were appointed to the President's Council for Science and Technology earlier this year. You've been recognized all over the melanoma community for all of the research that you've done, and you have made me. You're one of the 3 people I would say that directly impacted how I practice medicine. So I am honored to have you on this, Wednesday night. So I'm super thankful that you've come on with me.
Oh, awesome. No, I'm so excited and thank you. I mean, it's a great opportunity, and you're absolutely right. It's the last time we actually started working together, we also were in scrubs.
Yes.
That also tells you that actually was when I was a fellow. I actually had not worn scrubs for 14 years until this COVID crisis. But absolutely, I'm so excited to be here with you. And, for all of you, actually, Melissa and I worked together when I was a fellow. So technically, she taught me first about melanoma before I actually started, got on faculty. So it's kind of all your fault. But
yeah, it's a good way to win brownie points.
Yeah, but really excited to be here, and especially in this forum with AIM at Melanoma. I actually want to say a couple of words about Val, because Val Guild was such an important person for all of us in melanoma, but she was so important to me personally. In fact, when I moved to MD Anderson, she would take the opportunity of meeting every new member of my new team to tell them, and here's how I met Hussein. And she would tell them how she was at Pittsburgh giving participating in one of the symposia for AIM, and that was actually before the age of Uber, believe it or not, and so we were waiting for her car to take her to the airport, and it never showed up. So I'm like, I'll take you, it's fine, it's only an hour drive, it'll be okay. But so I actually took her on that drive, and we were, as we were talking, she found out that it was actually the day of my birthday. And so she ended up basically giving me all sorts of advice about life. And since then, we had been really very closely in touch across the board. And she's really mentored me through my melanoma career. So it's a big loss for me personally, as much as it is to the community.
Yeah, huge loss for the community. And it just goes to show you that, this Val's reach is just so far. I mean, she's impacted melanoma research and the community across the country. So, y'all.
And I would tell you, her opinion about our trials, especially mine, would actually change how I do things. And I think I refer to her as our moral compass, to be honest. And I think it's really in the midst of, kind of grieving for her, I really do think that knowing that Sam is there to take on the torch, and actually the foundation that she started is so strong and impactful in melanoma, I think her reach will continue. And so, and I guess that's as an example. So again, thank you for hosting me, and excited to have a scrub to scrub conversation, I guess.
That's right. So, I mean, I guess part of the thing that we wanted to try to talk about to start anyway is just kind of how COVID has sort of shaped some of the NCCN guidelines. And I know that, you had a large part in making those guidelines, especially with the brain metastasis recommendations. So I just want to kind of start at the beginning. So I know for us in our clinical practice in Pittsburgh still, really the changes with the neoadjuvant treatment has kind of allowed us to do things that we've kind of been wanting to do for a long time. And now are able to do with a little more frequency. If we want to speak to that first, we'll start off easy.
Yeah, no, that's fine. I mean, other than kind of making me buy scrubs, the COVID has really affected things in so many ways. And I think especially for cancer patients and for our entire institution, I know institutions across the country, it's been really, it kind of put things in perspective that, whatever we talk about when it comes to COVID is actually life and death. And, guess what, when we deal with something as significant as melanoma, it's always been life and death. And it's always been how many patients can we cure, how many patients can we save. And right. I can tell you that, when we started kind of thinking about our approach to COVID, the main question was, how do we protect our patient population, right? So cancer patients from the get-go, from the first data that started emerging out of China, it was very clear that cancer patients are at a disadvantage and that they have a higher risk of complications from COVID. And so I almost will use the sentence that MD Anderson uses a lot, in that we actually have the highest concentration of the most vulnerable population, right? Sure. So when we ask our patients to come in to the cancer center, to come see us to receive treatment, whatever treatment that is, we are already exposing them to the risk of being exposed to COVID. So one of the main concepts is, how do we protect our patients from the risk of exposure first? And when you put that in perspective, you start thinking, well, if I'm going to protect them from the risk of exposure, am I putting them at the risk of melanoma developing, growing, progressing? And how can we use the incredibly effective therapy that we now have? How can we use it to our advantage in a way that we can say, well, instead of taking somebody, say, to the OR and doing surgery on them immediately, ORs have actually become one of the hardest places to get into, because what? You need a ventilator to get a patient into the operating room and do an axillary dissection, right? So you have to put them you have to intubate them and use a ventilator. We all have heard in the news how important the availability of ventilators are. Sure. There could be complications after surgery that, maybe patients will need ventilators for more than a day or two. Again, if they get exposed to COVID and get sick in the hospital because of a surgery, what would that really entail in terms of their overall survival? And so immediately the thought started becoming, how do we avoid some of these interventions? Surgery is among one of them, not all of them, but surgery is an example, right? So for patients I want to highlight two things. First, there are regional differences. I can tell you that actually in Texas, it was a governor's executive order. And the Texas Medical Board, they said if actually surgeons took patients to elective surgeries, their licenses could be suspended.
Oh, wow.
And imagine who considers cancer elective surgery, right? You think about it, this is really important surgery. Well, their definition of elective was that if the patient, does not need to be wheeled down to the OR that day, that makes it elective, right? So again, there are regional differences, both in terms of the interventions themselves and in terms of the COVID density and, as we've seen in New York as an epicenter and other places in the country. So we as melanoma physicians came together and started thinking, what are the tools that we have that can help us strategize around this? How can we do things that prevent our patients from having to go straight to the OR, from having to come into the cancer center for, or be admitted to the hospital? So neoadjuvant therapy was actually a perfect example of that. And just to take it a step backwards, neoadjuvant therapy is kind of used in the context of preparing a patient for surgery and trying to improve their surgical outcome by giving them treatment ahead of surgery that can decrease the size of the tumor, improve surgical outcomes, and we think improve survival. So we've been doing, and actually Pittsburgh was the leading site for that. And then at MD Anderson, we've been doing a lot of this, where we're taking some of the effective therapies that we use in the metastatic setting, like targeted therapy with dabrafenib, trametinib, encorafenib, binimetinib, using those drugs for 8 weeks ahead of surgery. And then we've used immunotherapy as well, like ipilimumab, for, again, 2 cycles ahead of surgery. And we've seen that we can achieve, almost complete eradication of the tumor in up to 70% of those patients, right? And then we've seen, and actually this was just also reported at ASCO, that when you can achieve that and you do surgery, most of those patients actually, if they get a PAS CR, pathological complete response, never recur after that. So it's been really impressive. So one of the things we did with the NCCN guidelines is we said, wait, if a patient has a bulky nodal disease and your immediate thought is, I should take them to the OR and take it out, maybe you should consider neoadjuvant treatment with either immunotherapy or targeted therapy. On the one hand, you actually shrink down their tumors, you improve their surgical outcomes, you may actually improve the survival, and guess what? You actually leave them out of the OR for longer too. So
everybody wins. Yeah.
Yeah, exactly. Now, the interesting part of the recommendations for that we pulled together is, I think, is a slightly different variation in that in neoadjuvant clinical trials that you guys have been doing at Pittsburgh and we do at MD Anderson, surgery is absolutely planned after 2 cycles or so.
Right.
So we actually recommend it for people to look at, say, scans and decide if the patients are deriving benefit and the COVID situation is still either significant or unpredictable in the area in which they are. We actually still included a potential to extend that therapy again and try to, kind of delay surgery if needed. I do want to give a lot of credit for the NCCN guidelines to Susan Sweater, actually, from Stanford, and Ken Grossman and others. And there were surgeons on it that themselves recommended this, which is relevant. It's not just a medical oncologist saying, keep the knife away. It's actually us believing that, in conjunction with each other, we can really strategize around how to protect our patients and give them the best benefit.
So we saw, the information or the data out of ASCO, was that just with the PD-1 inhibitors and that, or was it both BRAF and like any kind of neoadjuvant therapy? I didn't.
No, so there are, I guess, 3 pieces of evidence there. One was a pooled analysis. So all of the people that do neoadjuvant trials across the melanoma global community came together in what we call the INMC, which is the International Neoadjuvant Melanoma Consortium. And we actually pooled all of the data from all of the different trials that included targeted therapy and immunotherapy. And in that, we've shown that that everybody who gets a PAS CR, regardless of which approach, generally does well. But if you get a pathologic complete response from immunotherapy, it's almost impeccable. Like there's been only like 1 out of, almost 88 patients that have recurred.
Sure.
What was just reported at ASCO was a longer-term follow-up on one of the neoadjuvant trials where that one it was immunotherapy and had 64 patients. And only one of those patients, after over close to 2 years of follow-up, has recurred that got a pathologic complete response, which is quite amazing. The other thing that Christian Blanc presented is a newer thought process, which is we were just talking about eliminating a higher morbidity surgery. So what they did, and this is really cool, they actually planted in the large lymph node that the patients would have, the bulky lymph node that comes in, they planted a marker, like a metal marker, and they treated, and instead of going with the standard of care would be to go in and take all of the lymph nodes out, not leave anything behind. We call it completion lymph node dissection or therapeutic lymph node dissections, as they called it in the study. So what they did in this one, the trial is called Prado, is they actually just took out that lymph node that had the marker. They didn't take out everything. And what Christian showed this, I was going to say this Saturday, but I actually watched it on Saturday. He probably recorded it a week before. but what he actually did show is that the pathologic complete response in that one node predicted the pathologic complete response in all of the other nodes. And their recommendation from this is probably to start doing less and less surgery. Still do it, but not do the big one. But that remains to be proven. That was their first cut of the data. And they said they're going to present the relapse-free survival at ESMO. So in a few months, we're going to see how many of those patients recurred and whether maybe if you didn't have the full surgery, maybe there is a risk of recurrence that's higher. So we'll have to wait and see.
That's amazing data. So I mean, I think for us, neoadjuvant was obviously one of the biggest benefits of COVID, sadly. But also it's sort of, we're seeing very similar recommendations across just adjuvant therapy in general, trying to choose, regimens that allow you a little bit longer time between things. And one of the things that we were really excited about is the higher dose of pembrolizumab to be given every 6 weeks. So I know, these recommendations and the need for time with COVID really sort of pushed that recommendation through, it seems like.
Yeah, exactly. So for adjuvant therapy, I think we should kind of break things down into a couple of pieces, right? So, first of all, you're thinking, what's the patient's risk of recurrence, and what is their capable, or what's their potential to benefit from treatment, right? So that's the first component on that. And the higher the risk, we know, the higher the likelihood of or the absolute benefit, right? So we know that these effective therapies, pembro, nivo, dabrafenib, and trametinib for patients that are BRAF mutated, we know that they decrease the risk of recurrence by a half, which is incredible. Like, I was talking to somebody the other day, and I said what we call a hazard ratio of 0.5 is like the dream of a clinical trialist, and it's realized already. Adjuvant therapy does decrease the risk by a half, which is tremendous. And so we look at that. What does that half mean? If your risk is 60% and we decrease it to 30%, that's a pretty substantial benefit. But if your risk is 20%, is that benefit, worth the treatment or not? So that's the first component. The second component is you do worry a little bit about the toxicity, because if you give patients, say, immunotherapy, and they get a toxicity from it that's an immune-related toxicity, right? So colitis, pneumonitis, how do we treat that? We treat it with steroids.
Right.
Why? Because we're trying to pull the immune system back and say, wait a second, you've gone too far. We need you to calm down. We need you to not attack, the lung, the liver, the bowel. When we do that, we're actually suppressing the immune system of an individual, right? So we're giving them steroids. What does that do? That makes them at a higher risk of COVID, right? So you have to really kind of balance that. Now, thankfully, immunotherapy has only, 10-15% risk of toxicity. It's not zero, but it's, I break it down, I say it's 1 out of 7, which is really kind of the 15%. So, 6 patients out of 7 will get away with it and not have to be on steroids. So we take that into account. The third part is, again, protecting them from exposure to COVID, which means bringing them to the cancer center less and less, right? So some people started saying, well, maybe that's why we should jump on the targeted therapy and do BRAF and MEK, because they take the pills at home, right? So, and that's great. That's a reasonable consideration. But also take into account that if you take those drugs, BRAF and MEK, you actually could develop fever. That's one of the most common side effects. Almost half of the patients get it. What happens if you develop fever in the age of COVID? People will freak out and want you to get tested. So unless you want a lot of nasal swabs, that's one thing to kind of take into account. So we built kind of a model in which we said, assess the risk of the absolute benefit for the patient. In the NCCN document, we said if the risk of recurrence is less than 50%, you can think about waiting this out to a degree. And we know that we have salvage therapies that are really highly effective if the patients recur. Again, thinking primarily about protecting the patients from having COVID and having immediate, threat to their lives. The second thing is, what is the risk of toxicity, which we just discussed? And then if you can bring them less, that's where the Q6 weeks pembrolizumab came along. Well, if we do pembrolizumab every 3 weeks, they're coming to the cancer center every 3. If they every 4 weeks, you've already saved them over the course of a year a few trips. If you go to Q6 weeks, then you cut out a lot of the risk, especially that we're saying that you're going to be, that hopefully COVID is a few months situation. So what people may or may not know is that the FDA was looking at the Q6 dosing at the same time. And early this year, the first indication was like, we don't understand why you guys are doing this. Sure, the data, like the PK data looks about the same, but who needs to approve something just kind of so that, yeah, right. So the FDA was very lukewarm about that. They were like not very excited about supporting that dosing. But part of COVID and part of our recommendations for melanoma are like, why would you not try to decrease, visits to the cancer center, exposure, all of that? And I think part of this, and I think the FDA has been honestly quite reasonable across the board. And I'm actually excited that that the current commissioner, Steve Hahn, is one of the most honestly reasonable people, and very, very patient oriented. And I think having looked at the situation and our document and others pushing for this to happen, it kind of decreased, I think, the barriers and allowed for this to be approved. So now we have that on our hands.
So one of the things, and you can choose not to speak to this if you want, but outside of COVID, we get a lot of questions about, which I'm BRAF mutated and I need adjuvant therapy, which one is better? Because when you look at like the, recurrence risk and all of that, they're very similar in terms of outcomes. So like how do you choose, personally between the two?
Yeah, so I'm might surprise you by the fact that I'm quite democratic about this, and so I actually present the patients, and I was just talking about this yesterday. I spend about 45 minutes discussing with the patients all of the elements of the data, and I think it's so important because, when you look at the efficacy between targeted therapy and immunotherapy in the adjuvant setting, they're absolutely the same. Mm-hmm. In fact, the hazard ratio that was originally reported for dabrafenib and trametinib was 0.47, which looked like it's better than the 0.54 that was reported for pembrolizumab. So this past weekend, the long-term data was presented from both trials. And guess what happened? The hazard ratio for dabrafenib and trametinib became 0.5, and that of pembro became 0.51. So like they're indistinguishable in terms of how effective they are. They're they have the same efficacy, although obviously different trials and people have to take that into account. What ends up being the main difference, and that's what I present my patients with, is the fact that, the toxicity percentage-wise, targeted therapy has a higher rate of toxicity, closer to 30%. And about 25% of patients actually stop because of toxicity. Yep. Immunotherapy, the actual numerical the incidence of toxicity is only 15%. So you're kind of talking about a lower rate of toxicity with immunotherapy, right? However, the main difference is with the pills, you stop the pills and days later, all of the toxicity goes away. Right. Immunotherapy, especially when it comes to endocrine toxicity like hypothyroidism, adrenal insufficiency, all of that kind of stuff. When a gland is destroyed by the immune system, it doesn't come back. And so patients can have long-lasting effects, but only in a small proportion. So it's a very tiny proportion, but that matters. If I have a 26-year-old lady who's not had any children and is worried about fertility, I think it's a reasonable thing to say, look, there is that tiny chance that I wouldn't say that you would become unable to conceive, but that there may need to be, there may be effects on how easy that would be. Sure. So when I put all of those things together, I sit with patients and I walk over this with them, and it's been really quite remarkable that patients make their choices based on these issues. Like I have a younger gentleman who works on an oil rig, and I'm in Texas, right? So and they're in the sun quite a bit, no matter how much I say you need to be protected. And the idea of taking dabrafenib and trametinib, which gives you a bit of photosensitivity and you can get a rash from being out in the sun, was just a was just a no-go because he was going to be working every day. So it was a lot easier to show up and get an injection or an infusion every 4 weeks. So it's never an easy decision, but it's always a fun conversation with patients, and kind of responding to their own values, I think, always ends up being the easiest way to help them make that decision.
So funny thing, and I know you'll be shocked about that. That's exactly how I approach it whenever I talk to people too. It's
well,
so weird. I can't imagine
well,
that
Melissa. That means you taught me well.
Or you taught me well, or both, I guess, right? But you're right. I think given all the data that we have, it's a mixed bag, and it depends on the patient. So this is like my opportunity to find out what my mentor thinks. So half of these questions are just mine because I want to know what you think. So moving into stage 4 disease, I know a lot of these same kind of things that you've already talked about, so I don't want to beat a dead horse or continue to belabor topics about this, but I think we've covered keeping patients underexposed, trying to weigh in the need for steroids and all of that. I know that we don't really have any data necessarily because we didn't really have any melanoma patients that were actively being treated at our center that got COVID, that became COVID positive. I don't know if you had any insight about that from a more global perspective, if there was any data even out there about how patients that do develop COVID while on treatment go, but we don't want to see that. Fingers crossed.
yeah. No, I mean, it's really interesting. Well, first of all, I think, if I may make a couple of general statements about COVID. I mean, the reality is, we've learned a lot in the last few months. We've had tons of data come out. In fact, it was interesting. We're actually involved in some AI approaches, artificial intelligence approaches, just to try to understand what's in the literature because of the absolute explosion of all of the information. On the other hand, it's a new disease that's only been around for 6 months. So there's so much we really don't know about. And so I think, the early data from China, as I said, was really concerning for cancer patients. And I think important for our melanoma patients to know that there are major differences between the original patients with cancer that were reported that actually mentioned, a really much higher rate of mortality among cancer patients. I don't think they apply as much to our patient population with melanoma. Most of those patients were older, lung cancer, smokers, other comorbidities, and more importantly, on chemotherapy, which is a really massively immune suppressive and probably associated with a high risk. Now, having said that, you can take the idea that we're not seeing a lot of data for patients on immunotherapy with maybe that there's some value to being on immunotherapy for you to not get COVID. So that's the bright side and the rose, kind of the pink colored glasses. The flip side to that is just that data has not emerged yet because, there's been so few patients that have been treated. My good friend Paolo Scerto from Italy presented at AACR their experience, and he said, I don't know, I didn't see enough of those. I think immunotherapy is protective. I'd be very careful making that.
That's a bold statement.
So I would say, and I tell this to my patients, that there are kind of 2 phases to getting COVID, right? There's the first one is to actually get the infection. And then there's, you could argue that maybe if your T cells are more effective, maybe you'll never get it and maybe you're a little protected. I have patients that tell me they never get the flu after I gave them immunotherapy. That may be the case. However, the flip side to that is the second part of the COVID infection, what actually makes people really sick and what gets all of the problems going is the vigorousness or the vigor of the immune response that the body mounts against COVID, which is kind of what lands people in the ICU, what leads to multi-organ, failure, all that kind of stuff. Well, guess what? When we give you immunotherapy, actually what we did is make your immune response more vigorous. So there's a chance and a concern that that part may become more severe for patients that are on immunotherapy. So it kind of balances out. And what I tell my patients, if any of them are joining today, is I simply say, I don't want to find out with you. I want you to protect yourself, to be as socially awkward as you need to be, to isolate yourself the most you can. Let's not find out.
No.
So prevention is absolutely the most important thing you can do. And really kind of seeing what's happening in the news and the fact that there are vaccines in the, kind of looming, I think highlight the need to get us through the next few months without getting infected. Whatever you guys need to do, masks, social isolation, distancing, and awkwardness. Highly recommended. And then obviously wearing masks and washing hands and just being extra careful. I think that would be, important steps.
And it's funny because whenever they first started flashing CT scans up on the vigorous immune response that folks were getting with COVID, I was like, that looks oddly familiar, like pneumonitis. Funny thing. So it seems like, or it would be intuitive to think that maybe some things like tocilizumab might be something that would be possibly a benefit in those cases as well.
Yeah, I remember you texting me that very early on. And I was like, how did you know they're doing a phase 2 trial already in Italy? Yeah, so actually it's interesting. I think, because we dabble with immunotherapy, because we've caused enough toxicity with it, and because we've, thankfully saved a lot of patients with it as well. This whole kind of vigorous immune response is something that immunotherapy specialists already know very well, and mostly melanoma specialists. So actually in Italy, I was just mentioning Paolo Ascerto, who's really the leading Italian melanoma expert. He was leading the trials for tocilizumab in Italy for all of COVID patients, not just for cancer or melanoma, just because we have that much experience. And tocilizumab is one of, now, I don't want to, necessarily condone a specific drug, but it's one of the interleukin-6 inhibitors. And interleukin-6 is one of the, kind of inflammatory cytokines markers that just shoots up and becomes really, really high in those patients and causes a lot of, or mediates a lot of the immune-mediated damage. And so we have antibodies to it. Tocilizumab is one of them. So it actually binds that cytokine and decreases its levels and prevents that surge in what we call the cytokine release syndrome. So, Melissa, you were right. And we're waiting now for the results of the phase 2 trial in Italy. They accrued like 400 patients in like 3 days. And so we're waiting to see what those results are going to be.
I can't wait to see, because it's just very interesting to me. And then the other thing that I really want to spend, because I feel like you and I could spend probably 3 or 4 hours talking through all of melanoma.
I have supplies. I can stay in the office tonight.
We'll just hydrate ourselves all night. One of the things that I wanted to touch on, because this is sort of your thing, is brain metastasis, and kind of where that, not only part of the guidelines, but also kind of where that's going. Because, when you were at the University of Pittsburgh, you pioneered all of this research. I still to this day talk about the study where you're doing PET scans on people's brains and not doing radiation. And I was like, it was the coolest thing I've ever seen. And so I think, you're like Christopher Columbus out there pioneering all of this stuff. So I just want to give you the opportunity in the forum to talk about that, because truly, those patients need this. This is so important.
Yeah, no, thank you, Melissa. Absolutely. I think, what's really most important to us, and I think, again, I started treating melanoma, as you know, in the days where we really had nothing that really worked. And I think it's really, as we started finding out that we can really cure patients and we can increase the rates of cure up to now 50% or higher, even in the metastatic disease setting, the first thought was, who are the patients that we're leaving behind? And I think that, there are multiple populations. I'm interested actually in patients that have autoimmune disorders that we never treat because we're afraid of the toxicity. So that's one population we're leaving behind. But the brain metastases population was absolutely left behind, mostly because that's how we've done trials for 30 years, not because it made any sense. And so,
right.
Again, I credit Dr. Kirkwood for his mentorship and pointing me in that direction as well, and saying, well, let's see how we can change that. And so we started treating patients with brain metastases, and we started making trials that, instead of excluding the patient because you have a brain metastasis, it became the only reason you can get on trial. So you can imagine that at MD Anderson, I've really invested a lot in this. So I have 5 trials for brain metastases, and it's gotten to a point where sometimes I look at a patient and say, I know this sounds really scary, but if you have even a tiny brain metastasis, I'll have a great trial for you. It's actually, but the point is that we got to a point where we know that that's not as scary as it used to be.
Right.
We know that our immunotherapy actually works. We know that our targeted therapy works. And as we always as it happens in science, we've actually proven that immunotherapy works and that effect lasts as long as it lasts outside the brain. But what we also uncovered is that targeted therapy works, but its effects are much more short-lived than even outside the brain. So we have a lot of unanswered questions in that space and ways to kind of try to think about how can we improve the outcomes of patients with different approaches. So we're doing triplets, for instance. We're doing targeted therapy with immunotherapy, with anti-angiogenesis inhibitors, all of the things that can work concomitantly together to target specifically the microenvironment of the brain that's really different than the rest of the body. Now, having said that, I think the things that we know as they apply to COVID are very important. So we know that IPI and Nivo in combination is the most effective approach that we have for brain metastases right now. And we also know that you have to use the higher doses of IPI and Nivo.
Right.
And so that's actually a unique place in melanoma where the knowledge is quite clear that we know that this is what we need to do for those patients. And so as we were debating in these guidelines, when you use a high dose of IPI and Nivo, that does come at the risk of 55% toxicity. So it's hefty. And again, remember, steroids are the way we deal with these 55%. So we're kind of a little bit concerned about it. However, so some people were like, well, why don't we just use the targeted therapy just to get us through the next few months? And so that's when I kind of participated in that piece. And I said, well, let's look at what the overall outcome is. We want to go through the next few months, but we want to cure our patients forever. And so we really need to be very careful about proposing using therapy that could be suboptimal, like targeted therapy. So we kind of described in the document a little bit of what would make me absolutely treat with high-dose ipi-nivo despite all of the risk. And it is basically patients that are asymptomatic in the brain and they have lesions that are not very large to the point of giving them symptoms or requiring steroids. So we know that population does very well with immunotherapy.
Okay.
If patients are having symptoms like headaches, weakness, numbness, seizures, things like that, or require steroids because of the brain metastases, their immune system, we think, is too suppressed to respond to immunotherapy. And in those patients, using targeted therapy is reasonable, and we've shown that immunotherapy may not be the best approach. So we try to kind of help pragmatically with how to choose the patients to do this versus that. Again, taking into account the toxicity. The last thing I'll say is that, we know that lower doses of IPI seem to be quite effective. IPI plus Nivo at 1 + 3, 1 milligrams of IPI and 3 of Nivo. It's quite effective. The efficacy is about the same, a little less, but not significantly less. And the toxicity is about 20% less. So a lot of people are like, why don't we just use the lower dose? I would say for patients that don't have brain metastases, that's a reasonable approach, especially in the days of COVID. But for brain metastases, unfortunately, I think we have such an effective approach that we can't compromise on it in the short term, because the long term is significant. I mean, our PFS data now out to 20 months for those patients is 60% without any progression. So
that's amazing.
Yeah.
And everybody, and we've heard this, cancer doesn't stop for COVID. So you have to think of the long-term goals instead of the short-term goals.
And one thing I really do need to specifically bring up is actually how crucial it is to involve the radiation oncologist in that decision. So that's where the brain metastases clinic came along at MD Anderson, because we see patients together as a neurosurgeon, radiation oncologist, medical oncologist, and a neuroradiologist. And we all see the patients together and kind of devise, like this looks like it needs gamma knife now, and we can delay treatment for, another 8 weeks, and then you can do immunotherapy. Or the flip side, where we say, this patient doesn't really need gamma knife right now. Immunotherapy we know works. Why don't we do that for now and kind of delay gamma knife unless they need it? And we make that decision concomitantly. So I think it's gotten to a point where we've learned so much from each other in these disciplines that we are much more strategic about that decision.
Yeah, and I think see, this is when my mouth stops working right about now at nighttime. Multidisciplinary clinics like that are becoming way more common because it just is such a much more efficient way to get medicine done. So I think, you know, it's such a good, I'm gonna take that back to our clinic and say I think we should start doing a brain clinic. One of the things that I did notice though, like with the NCCN guidelines, is that it was recommended whole brain radiation is not recommended for melanoma metastatic to the brain. Now that's something that like we tend to recommend outside of COVID anyway. Is that COVID specific because of the immunosuppression, or is that just in general because of what we know?
Well, forward? I mean, at the end, we were trying to provide guidance to the practicing oncologist in the community as much as the melanoma specialists, to some degree know this. And so, and we have phase 3 data from Australia that showed that whole brain radiation actually doesn't help in melanoma. And so, so we're trying to say, again, if people were in the community concerned about their patients, worried about using immunotherapy because of all of what we discussed of toxicity, steroids, all of that, and end up saying, well, the standard of care is whole brain, it's fine, let's just do whole brain and move on. We were worried that that would actually give the patients a suboptimal treatment and not allow them the benefit of still potentially getting cured, where whole brain is at best palliative, if not even, not effective. And, and just to kind of take a step back, I think I respect the radiation oncologists' points around whole brain, where they use whole brain for breast cancer, for lung cancer. They have phase 3 data that says that it improves survival and it's a palliative approach. And until about last year at ASCO, in melanoma, we would always say to them, but it really doesn't work in melanoma. We didn't have the data. We just had our personal experience.
Right.
The Australian data that was presented at ASCO last year, it was actually the talk right after mine, or before mine, I believe, which was perfect because this, Dr. Hong from Australia presented this phase 3 data to say whole brain radiation doesn't work, and it was a perfect kind of segue into me saying, well, guess what, immunotherapy does. Which was really good, because it's, again, our patients deserve to get the best possible treatment with the best chances for long-term survival.
Yeah. So we're like 40 plus minutes into this, and we really haven't had very many questions, and I don't know if that's because you're doing such an amazing job teaching everyone that
or I managed
getting all our questions answered.
Or I usually, when I give a class or I actually can give a lecture and can see people, I just really count how many I can put to sleep, and that would be my success. I might have kind of just done that virtually.
No, you're getting all kinds of love in the comment section about how you're the best. And in fact, it's funny because there were 2 people in the beginning, and it made me chuckle, so I'm going to share it with you. Kate and Austin Bond were like, hey, if she gets tired of talking about how great you are, we'll chip in.
Oh, hi, Katie and Austin. Thank you.
So I think, I think all in all, this has been really good for everyone's brains, especially mine. I love how you explain everything. And that was something that, like I said, you really have shaped the way that I talk to patients, because you're a very good educator. You are very good at explaining not only what you're doing, but why you're doing it. And I think that it's a service to everyone. I couldn't be more blessed that I got to pick your brain for all the years that you were in Pittsburgh. And I hope I can think of some way that you can come on here and talk to me and do this again, because it would be extremely helpful. To me, I miss this interaction quite a bit. So please come back if we can come up with other things to talk about. I'll think of something, I'm sure.
No, thank you so much. It's always fun to talk with you. And that was kind of, we would sit at like 9 o'clock at the end of a really long clinic and literally debate science and which trials we should have. So this is a reprise of all of that.
That's right. I'm like, I have some questions that we need to talk about. Oh no. So, all right. Well, I'm thankful. I hope to see you soon.
Thank you so much.
Bye.
I really enjoyed this and I really appreciate the opportunity. You guys all have a great night. And remember, protect yourself from COVID. Masks, wash,
That's great.
stay awkward.
All the things. If there's any other questions, I'll handle them offline. We'll talk to you guys soon.
Thank you.
Bye.